In this lecture, I want to look at the concepts of compassion and dignity as core principles in palliative care, and I want to tease them out, looking at them through religious and spiritual kind of through that lens. And we've talked quite a bit in this course about the fact that palliative care and hospice care bring in these religious impulses. The whole thing is structured from a kind of religious understanding of the human self and human relationship. But it also sits very uncomfortably and in tension a lot of the time with biomedicine. And one of the truly radical things about what Cicely Saunders was trying to do was to bring these two things together. And it's easy to say that, but it is difficult to do in actual practice. So I want to look at this by focusing on compassion and dignity and how this sort of works within the larger healthcare system. So the terrain of biomedicine, I talk obviously a lot about this in my health and healing course. Some of you I know have taken it. Is materialist. It sees the body as a machine. So these ideas, these other more humanistic religious ideas, obviously many healthcare workers believe in these ideas, whether they're religious or not. But as I said, it's still a kind of a tension. And so it's certainly been my experience that in the Canadian context anyway, the healthcare system is deeply uncomfortable with even speaking about religion or spirituality. And there was a 2021 article written, actually the lead author teaches at Nipissing, Manuel Latalian, The Influence of Religiosity and Spirituality on Healthcare in Canada, a systematic literature review that was in the Journal of Religion and Health. And it showed that in Canadian healthcare anyway, the vast majority of people that were surveyed said they did not get any training in this. So again, as I've said throughout the course, this is one of the reasons that I have developed these courses. And I think they're very important. But there is always that issue of, I mean, I'd be interested to get your feedback on this. Shouldn't we just be studying how to give medication and things like that? If I'm a healthcare worker, isn't that what I'm doing? So the sort of the more humanistic side, unfortunately, I do think it often gets lost. So I do want to bring this back into focus in this lecture. I want to start with the concept of compassion because intuitively I think we all feel that this is at the center of not just palliative and hospice care, but all kinds of healthcare, hopefully. And it's, again, a word that we use all the time and we don't really think about it very often, perhaps, what it actually means. And so I'm taking this from Compassion, Luxury, or Necessity, written by Carol Taylor and Susan Walker in the Oxford Textbook of Spirituality and Healthcare. And I actually met Dr. Taylor. She came to a conference that I helped to organize on religion, spirituality, and healthcare. And so she's was a nurse for many years, and she's a nursing professor, and so she's written and taught a lot on these topics. And so she starts out, the authors start out the chapter talking about how a person feels within going in for certain procedures that are very invasive, like a colonoscopy and so on. And I've talked about this in my other course that for many of us, or not all of us, going into these settings is really like going into a foreign territory. So you feel very vulnerable. So she quotes here that the patient said that I had predominantly felt more like a product on the fast-moving conveyor belt of a healthcare factory than a human being. Why do we tolerate an environment in which a reticent but unafraid patient emerges from an uncomplicated encounter feeling dispassionately processed rather than embraced? So many of us have had discussions about this, so the patient here is talking about things like the practitioner not making eye contact, Um, they were methodical, pleasant, but detached, felt that they wrapped her tight within a cold, impersonal cocoon. And then another healthcare person comes in, a doctor, and says endeared himself to her because he battled with the curtain. So he tried to ensure that she had privacy. So he was recognizing her need for privacy. And At one point, he covered up her leg with a blanket. So this idea of he was demonstrating that he was sensitive to her needs and caring for her and trying to make her comfortable. And so in this chapter, they're looking at how do we maximize that. And I would just like to say this, I don't think this has to do just with healthcare. I think that these forces are in our society at large. So, for instance, in many, many professions, I'm hearing that all of the paperwork, so teaching, psychology, that you're having to do so much admin, so much paperwork, that the human part of the job can sometimes get pushed into the background. So I want to make this clear. I'm not talking about this. Certainly compassion is a concern for all human beings. So so in this first page, they talk about the idea that the forces that work against compassion is the fact that what's rewarded is not taking time, right? Generally within these systems, and again, not just in healthcare and everything. So what mitigates, what works against showing compassion? The reward system, the time demands, the organizational culture in the mid to late 20th century. So they write, and this is in the American context, but it's pretty similar here. Moreover, during that time, American hospitals embraced a culture that extolled rationality, clinical professional skills, and technological advances. And then in the particularly American case, this increasingly market-driven and bureaucratic approach. So as we've talked about in this course, in the American case, the healthcare system is a money-making system. So that even makes it more, if any of you have watched The Pit, you see the way that that corporate agenda is also really impinging on those traditional approaches of compassion. So I want to just look here at some of the different roots of the word compassion and the sort of equivalents in different languages. And so the Latin root pati or pati passes to experience with. So that's a very important kind of idea within this, that you're not doing that. You're not detached. You're not looking at this person clinically like a specimen or an object. You're with them in some sense, emotionally. And in Hebrew, racham, to love, pity, or be merciful. So certainly the hospice palliative care that's coming out of that Judeo-Christian tradition is pulling from these concepts very strongly. Now, of course, these concepts exist across culture because we're human beings, and as they say in this chapter, compassion has to do with human relationship and a proper form of human relationship. We've talked a little bit already in this class about the Jewish theologian Martin Buber and the I-thou relationship, that you don't interact with a person as an it. We know, certainly, I know if somebody's treating me like an it, I feel it immediately. We all do. So that idea of that this interaction is based in compassion. So in the Buddhist tradition, the concept metta, or loving kindness, benevolence. So they're slightly different, obviously, within different cultural constructs, but certainly within the Buddhist tradition, compassion is absolutely central to the tradition. And many years ago, we were lucky to have the abbess of a Buddhist monastery come and speak to the class here at Nipissing. And she was talking about the idea that many of the Buddhist practices are about training you in compassion. And I found this has always stayed with me. And I'll be talking about this more towards the end of this lecture, the way that we can develop it. It's not just that it's there. And she said, we're all training to be these compassionate people. So I'll talk about that more later, but I found that really reassuring, that it isn't just some people have more compassion than others. It's a resource that we can all draw on. So in Hinduism and Buddhist karuna, the selfless desire to alleviate suffering. So again, this impulse to alleviate the suffering of others is a very, obviously, hopefully, a very human impulse. I would just say here that I've been struck in my courses on religion over the years of the naivete sometimes of people, that it's a given. I think we can just look at the world around us and say it's not a given. I wish that were the case, but I do think that often in many, many settings, it's up to us to push back, to create space for this in systems that aren't always, they're not very hospitable to these more personal elements. So in Arabic, Ar-Rahman the Merciful. So in the Muslim tradition, there's the idea you can't depict God in painting or other forms of representation, but there's the idea of the names of God, and one of the names of God is Ar-Rahman, the Merciful. So from the Muslim point of view, mercy, compassion is an element of the divine. So we see this in all the religious traditions, this idea that this particular quality that I think exists in all people except for maybe psychopaths, but this quality is actually has a divine origin. Carol Taylor includes her model of professional care. I'm going to just touch on it. I don't expect you, obviously, to memorize this. I just wanted to include it as an example of how in the nursing profession some people are trying to include this within curriculum. It's challenging because as soon as you start to do this, you start to distance, right? So, and the last thing most of us need is more charts and bullet points. So but I do want to include it. I think it is important what she's trying to do here. And so she's trying to include within the actual curriculum the idea of bringing compassion in. So experiences positive regard for the person being cared for, affection. So you can see right here is bringing the emotional side of the clinician on board, that we don't have to be robotic automatons. And I think this is true in many professions. There seems to be this kind of background belief that we should act like we don't have emotions. I understand, nobody needs their professor or doctor weeping copiously. No one's talking about that. But certainly compassion requires emotional engagement. Intellectually grasp what is necessary to care. So again, this multidimensional approach, and we talked about this with the idea of total pain, that these things aren't mutually exclusive. We can bring them all on board. So we can have an emotional feeling connection, but we can also, obviously, if it's in a healthcare setting, it has to be following the protocols of healthcare. So intellectually grasp what is necessary to care, uses expertise and energy to secure the well-being of the person cared for. So we've talked quite a bit about this in this course, this idea that one of the most radical things seems silly, but it's very radical, the way healthcare has evolved, that it's about the patient and what's best for the patient. So that's why it requires that kind of sense of compassion, because you're paying attention, using that example of the doctor, that the woman's feeling uncomfortable because there's no privacy. So you're attending to that. The person is empathetic. There's a commitment to care and demonstrates caring behavior. So she's covering sort of all these domains. So there's the idea of the theory of it, but also you're demonstrating it through how you're acting, that you're showing care for this person. So in the chapter, they talk about an article by Graeber and Mitchums that interviewed 24 hospital clinicians, multidisciplinary, who were identified by administrators as being exemplary in caring and compassion. Analysis of data indicated that the clinicians did not attempt to distance themselves, but developed warm, empathetic relationships with patients. The researchers identified 4 levels of clinician-patient interaction in 3 distinct domains: the degree of intimacy between the clinician and patient, the inner motivational source for the clinician's interpersonal and affective behaviors, the comparative amount of personal focus and concern. So these ideas of the way in which they're able to show that they're not detached from the process. And again, I think this is true of all human beings, that often when somebody's trying to be detached, there's a fear of being drained, and I'm going to be talking about that a little bit later in the lecture. Of all of these professions, all of the so-called caring professions, there is always this is always a clear and present danger. So there has to be a kind of a balancing there with boundaries. So that's always tricky. So so the accounts of patient interactions illustrated some important differences between compassionate care and ordinary care. Specifically, the ability of compassionate clinicians to transcend their personal concerns or issues, which became, if only temporary, irrelevant. So that ability to look beyond the self and one's own issue, maybe you're tired or impatient, but you're able to put that aside and think about the well-being of the patient. So the quotation here is, the clinicians we observed did not appear to sacrifice rationality and objectivity in practicing compassionate care, but were able to balance the head and the heart. Compassionate interaction with patients are only one aspect of holistic care. However, in our view, the caring and compassionate clinicians in our study possessed a key quality, the ability to simultaneously care for the body, emotions, and spirit of their patient. Okay, so this is interesting, and based on research that that you don't have this. This is a common idea that if I access my emotions, I lose my rationality. So what this appears to be showing is that's not in fact the case, that these two can be running alongside of one another and are just dimensions of care. I think there are very few people that are going to argue that bringing compassion into various settings is a good thing, is always a good thing. But I think that one of the issues around this, and I think one of the barriers, is the idea of compassion fatigue. So I do want to address this. So on page 141, Taylor and Walker talk about the characteristics of compassionate individuals: tender heart, routinely moved by the needs of the most vulnerable to the degree that our spirits are afflicted. We talk about the needs and suffering of others. We grieve, we lament, we experience and demonstrate the ability to be moved by the plight of humans in needs. So I think we all recognize this in people who are kind of open-hearted and see and feel the suffering of others. So this is important because it can be very tempting, and this goes way beyond healthcare. For any of us, just reading the news, walking down the street and seeing homeless people, it's very tempting to just shut your eyes and turn that off because it's overwhelming. And certainly I have days where it's a day I have to just kind of shut the door and not think about things. It's overwhelming. So I think we have to take seriously that we're expecting this of people, but we also have to support it in people. Authenticity, you know it when you see it. As one of Walker's patients stated, it's hard to describe, but you just know someone has it. So the idea that you can feel that empathy in somebody. We should be knowledgeable about and moved by the plight of the needs of others. A portion of our interest, time, expertise, money should be invested in redressing local and global injustices. So this idea of this is the many ways that we can show compassion. And then they go on to talk about the idea of compassion fatigue, which I know I have a number of nurses in this group, and I know I think I have a number of social worker or people who are studying to be social workers. So these professions in particular are challenged in this area. But I would say people taking care of the elderly, people taking care of small children, really just all humans are constantly being challenged in this area to not fall into compassion fatigue and then kind of shutting it off. So they describe this as the 5 challenges in compassionate caregiving are burnout, secondary trauma, moral distress, horizontal hostility, and structural violence. So I want to talk about this idea of burnout. And I think I use this image of the gas tank because I actually think this is where material metaphors are good. That this makes, I think, intuitive sense to most of us, that the idea that we can only give to others if the tank is full or at least not empty. And again, we talked about I think we talked about gender at the beginning of the course. This can be highly gendered. It's not always, but that there is almost a cultural construct that teaches that women should just be endlessly compassionate and caring, uh, and nurturing. And so I think this also reads out into a lot of the caring professions, whether the person is male or female. So whether you're working for a charitable organization, you're just supposed to give endlessly of your time and never complain and these kind of things. So I think it's important to address this idea of this is where there's a danger in the religious ideal, because the religious ideal, there's no limits. And that's appropriate. But in a human life and how we live in a human life, just psychologically, we know there have to be limits. So if I'm a psychologist or counselor, I have to have proper boundaries. I just took a course actually, and the person who was teaching it, a psychologist, was talking about how if you're counseling people with trauma, you can become traumatized by hearing it, because if you're a compassionate person, it impacts you deeply. You might lose sleep over it. So these things need to be taken really seriously. I know people paid lip service to it, and so I really feel in this area, religion and spirituality has a lot to offer in terms of resources, actual resources for how you build compassion and how you maintain it. And so I'll look at that towards the end of the lecture. The word dignity, like many words, we think we know what it means, and then if we sit down and really try to figure out what we mean by it, it's difficult to say. And it's been something I have noticed over the years, is that the assisted dying philosophy has really kind of taken this word over, as though their version of it is the only version. And I think it's important within palliative and hospice care to push back against that, or in healthcare in general, that all these domains are interested in maintaining human dignity. And so I do think also, when I have heard, we can talk about this more when I talk about some of the controversies around Nipissing Serenity Hospice, that when you really start listening to what people are saying, what they often mean by dignity is autonomy. And this is a very Western secular view of the human person, that human beings need to be independent, completely independent. And if they're not, they lack dignity. And that is certainly not the view of religious traditions around the world, that there's the idea that, human beings take care of each other. We've always taken care of children and the elderly and people who have disabilities. So the idea that you're not always completely independent is nothing shocking. But so I think it's really important to be careful that we don't equate dignity just with autonomy. So that can be part of it, because for many people that is very important, but that is not the only meaning of it. So in the next chapter in the book, Dignity: A Novel Path into the Spiritual Landscape of the Human Heart, they talk about trying to create these kind of medical empirical frameworks within healthcare. And so these are seen from within healthcare, but I think they're important regardless. So receiving adequate pain and symptom management. So we know that from the earliest days of hospice and palliative care that this was a central concern, that obviously the spiritual aspects were important, but that could only really come if the pain was handled. And this is very important, because both from a Buddhist perspective and a Hindu perspective, a lot of the time, the idea is that the person should be conscious at the moment of death. It's actually a religious value. And so if the person is properly medicated so that they're not completely unconscious, this is considered very desirable. So avoiding inappropriate prolongation of dying. And again, this is something that we've been grappling with as a society, of where is that point. And this takes us back to those very first discussions we had in the course about end of life and directives and so on. And if many people in our society are kind of in a state of death denial, or they don't want to talk about it, then this can happen, where the family's just prolonging the life, or the person themselves is prolonging the life kind of without thought. So this is a very important discussion that's being had around not, for instance, in late stages, doing constant testing on the person, for instance. Relieving burdens. So the role of that interdisciplinary team in relieving the burdens of people and helping them and supporting them is obviously a key part of hospice and palliative care, and then strengthening relationships with loved ones. So we can see, although this is not specifically about hospice palliative care in this chapter, it fits perfectly within it. And so they talked about the idea of these aspects of dignity, such as a continuing sense of self. And this is an ongoing challenge within healthcare because of those forces I talked about already, of how alienating that atmosphere can be. It can be very difficult for a person to maintain that sense of self. And so anything that we can do in terms of the design of these places and protocols, that should be done. Maintaining hope, maintaining as much autonomy and control as possible. So these are all really important aspects of healthcare in general for helping people to maintain their sense of self and their sense of dignity. I wanted to end with talking about the resources that religious and spiritual traditions have to offer, and it's important to note that these are for both the patient and the caregiver. Both can benefit from it. And certainly Dame Cicely Saunders, it was important for her that each hospice should have, in her case in St. Christopher's, they had a chapel. It's been changed now, but like a room where people can pray or meditate, and the staff can also use that room. Carol Taylor talks about the idea of compassionate presence. Now, the idea of being fully present, that's important for a number of, if not all, the religious traditions. And it's also an important concept within psychology itself, that so much of our mental energy is taken up with the past and the future, and also just ruminating on our own problems and worries, right? So that idea of coming fully into the present. And, you know, we can talk about the many challenges to this with social media and people just always being on their phones. It's just amazing to me to watch two people at dinner both on their phones, like just not present at all for each other. So we have many forces taking us out of being present to one another. So I think this is where religious and spiritual traditions can really come in and help us. And I'll be talking about some of those practices just in a moment. And so this is one of the key aspects of working with burnout and maintaining oneself. I think these traditions have a lot to offer in very concrete ways. So just to give some examples, I always ask my students to share with each other what some of their tricks and practices are. And certainly we're late in the term now. We're coming to the end of the term, and I think we're all feeling the exhaustion. And so while this is obviously very important in the caring professions, it's important for all of us. And so just one example that's very common practice, both for healthcare practitioners and the people that they're working with, is prayer. Now, let's be really careful here. I'm not saying that doctors and patients should be praying together. And this is why I think there's often this idea of like we just shouldn't have religion in healthcare, because there's the specter of people trying to convert people on their deathbed. It's horrifying, the idea of that. So obviously this has to be done very carefully. But certainly I know I've interviewed doctors who are religious and nurses who are religious, and it's just part of what they do. They're religious people or spiritual people, and they have their own practices that support them in what they're doing. They don't necessarily share it directly with their clients or the patients. So prayer is just a pretty universal practice across religion that we know too many surveys to count now, the ways in which prayer contributes to both mental and physical well-being and health. Other practices are meditation. I know many psychologists have a meditative practice that helps them be present for their clients. So I'm going to be attaching a few different examples of this just to give you an idea of how you could work with this. And so I think this can be intimidating for people at first, this idea that I have to do an hour of meditation, and that's just sort of another thing to add to my to-do list. So this is not that. The other aspect of this is that we've talked a lot about the idea of living in a multicultural, multi-religious society. So for instance, smudging, and I'll be talking about this when I talk about the Nipissing Serenity Hospice. It was built specifically so that there could be smudging done within the facility. So it allows people, this is a very important part of maintaining people's sense of self and being able to be their authentic self even within that setting, is being able to do these cultural practices. So another is nature. And so certainly in Indigenous traditions, that idea of nature itself as being sacred and healing. And I think many of us just know this to be true, that if you're feeling particularly frazzled, just walking by the lake or walking in nature is in and of itself helpful. So I do think this is something I'm very interested in, is we can tell people, they have to beware of burnout and they have to develop boundaries, but we often don't give them the resources or help them to find the resources that they need to do this. So I think this is something it's very important to engage with. If we're going to ask people to do extremely challenging jobs where they're caring for others, or even just in our day-to-day lives, asking us to keep, looking at the news and keep caring, we have to also have these resources for ourselves. So I'll be interested to hear what you have to say about your own practices and your own resources.